board meeting on Thursday, 10th of October. So as usual, just a reminder that we are being live televised, so make sure the camera doesn't fall on your laptop or be careful. Right. And so as usual, what we will do is we will go around, introduce ourselves, starting from here. And before that, let me welcome Vicky McLeod. Thank you for joining us, our new member as a Director of Children and Youth Services, and you are replacing Graham Writer. Okay, I understand he has retired. Welcome to the board. So let me start with myself in the introduction round. When you do the round, please press the mic and then speak and then switch it off. Okay, so I'm Councillor Paul Egil-Shelvan, Councillor from Cramlington Southeast. I've been chairing this Health and Wellbeing Board meeting for a while.
Hi, I'm Graham Sires. I'm a GP in Alnwick. I'm a clinical lead with the ICB in Northumberland.
Morning everyone, I'm Jill O'Neill, Executive Director, Public Health, Communities and Inequalities based in the Council.
Peter Stanfield, Chair of Health Watch Northumberland.
Sharon Williams, Community Pharmacy, North East England.
Good morning everyone, I'm Jeff Watson. I'm the Cabinet Member for Healthy Lives and also the County Councillor for Amble West with Warkworth.
Hello everyone, Neil Bradley. I'm the Executive Director for Adult Services here at the Council.
Morning everyone, Vicky McLeod, Director for Children, Young People and Families.
Morning everyone, I'm Graham Binning and I'm the Northumberland Fire and Rescue Service Chief Fire Officer.
Morning everyone, I'm Sam Anderson, one of the Service Managers for Grown Healthy 0-19 service.
Good morning, I'm Rachel Mitchison, Director of Delivery for Northumberland and North Tyneside at the Integrated Care Board.
Morning, I'm Mark Purvis, County Councillor for the College Board in Ashington.
Morning, Chloe Mann, Place Director from CNTW.
Hi, I'm Ross Wiggum, Exec Director at Northumbria Healthcare.
Hi, I'm Abby Conway. I'm the Chief Exec of Citizens Advice, representing the voluntary sector through Thriving Together.
Good morning everyone, I'm John Liddell. I'm a Senior Public Health Manager with the Council leading on sexual health.
Morning, Andrea Todd, Democratic Services.
Apologies for absence. Any apologies for absence?
Chair, we have apologies from Councillor Jones, Kevin Waring and Russell Nightingale. Anybody else? Any other apologies?
No, thank you. So the second item is minutes. The minutes of the earlier meeting on 8th of August had been circulated. If there are no comments, then I'll sign it as a true record of what happened. Is that okay? Thank you. Disclosures of interest. Any disclosures? We have three major items: sexual health, local principal social worker report, and children and young people. There is no disclosure of interest. Now we move on to the main item on sexual health strategy. Just a brief introduction from me. I think it can be said, better late than never. That's a famous saying. So we should have done it a while ago. But thank you. Finally, we did it. Thanks for your efforts, Jill. And the principal thrust of this report is basically, again, on prevention. to quote another saying, it's prevention is better than cure. So that is what the emphasis is going to be, if I understand correctly. And that's where our strength is also. Like, we leverage our strength to apply prevention wherever possible. So the strategy is being presented, so all comments and discussions are welcome after the presentation. John, it's yours.
Thank you, Chair. So yes, I'll do a fairly brief presentation, maybe 5 or 10 minutes, and then happy to take questions after that. Are we okay there? It's okay. Okay, I'll get check the clicker works. I'm going to have to rely on. Down. Got you. Right. Okay, so just to start, really, just a little bit of context. So you'll be aware we've got a sexual health service within the county, of course, that the local authority commissions, and it was during the recommission, which was finalised last year, that we kind of got thinking about the strategy, really, because the service is delivered in partnership with Northumbria Trust. That's a little picture of the service there, if you're not familiar with where it is. It's in Blythe. The headquarters are in Blythe anyway. And that's a list of what the service is commissioned to deliver. And what kind of came apparent when we were developing the recommission was that there was lots of other stuff going on in the system. Basically, that the service was kind of essential to delivering, you know, those interventions. But there was other stuff going on across the county, and we needed to, I suppose, assure ourselves that we were kind of knitting all that together to ensure that residents were getting the best possible services. So it kind of, there was a few new things went into the commission, but by no means did it kind of cover everything that we wanted to do. So we'd completed a needs assessment in 2021, and one of the key things that came out of that, the recommendations, was at the top bullet point of there, was that we developed a strategy to talk about what else is going on outside of that immediate service and what else can we do. There was a few things in there. You see the second one, expansion of digital service, for example. We included that in the new service, and we put a bit of money, additional kind of funding in the service to kind of cover that. So we did. The service has been kind of developed from what it was previously, but as I say, there's more that we wanted to kind of look at, certainly around prevention and how we kind of ensure that the right messaging is getting out there within our communities. People get information, services, interventions, advice around sexual health from just an enormous range of areas. You know, we're fairly confident that, you know, on the right there, we've got our own service. It's a good service. It's effective. It's a long-standing partnership we've got with the trust. We're confident what gets delivered from that service is sound. It's up to date, and it's appropriate for the patient group. Obviously, we have less control about what goes on elsewhere within the system. Certainly, social media is an interesting one about where people source information from, and isn't something that we can necessarily control, but we can ensure that we put the right messages out there. Pharmaceutical industry, of course, has a role in this. So there's lots going on. So a lot of kind of noise in the system, if you like. So the strategy was a way of, as I say, of trying to identify where people were getting information from and how we can ensure that it's of the very best quality. So I've just put this in as an example. I didn't want to kind of load this too much with a lot of data and graphs and things, although there's two in the presentation. This is one of them. I suppose it's, you know, why is it important? Why does it matter? So this is a fairly straightforward indicator, and it's detecting chlamydia within females. So traditionally, as part of your sexual health service and in your provision, you would monitor chlamydia detection alongside a range of other things for men and women. But it was flagged around about 2021 nationally that really the focus needs to be on women. Chlamydia is very easy to treat once it's identified. It's quite easy to catch as well, of course. It does primarily affect young people. It's, as I say, it's easy to treat, and once it's caught, it's treated. You shouldn't suffer any ill effects, lasting effects from it whatsoever, unless you're a woman and it's not caught, it's not treated, okay, because it can cause infertility in later life, okay, incredibly serious ramifications. And this can go undetected for, you know, if someone was, say, 15, 16 when they contracted it, this could be years later when this person decides to have a family and then discovers that because this wasn't caught in time, that's been denied them. So we can see just from the graph there, we saw a drop off in detection rate that is linked to the pandemic, of course. But once we kind of put our shoulder behind this and said, well, we're going to focus on this, we have seen an upturn where, you know, we're at a rate that is comparable to the England trajectory, which we're pleased about. But obviously, this is an area we want to do more in. So I've just chucked that in as an example of how sexual health can kind of impact on populations. So sexual health and inequalities. There's a theme running through the strategy that we were very kind of you know, absolutely certain we wanted in there. We wanted it to address inequalities. One of the priority areas isn't in itself inequalities, and inequality is a theme that goes throughout all of the work, because sexual ill health isn't experienced proportionally amongst all populations. It's undoubtedly linked to inequalities. We've got a disproportionate level of harm is experienced by women, young people, gay, bisexual men, black and minority ethnic groups. So a significant portion of our population can suffer ill effects disproportionately by sexual ill health. So the little chart at the sides, I'm just checking to see how clear that is for everyone. So essentially those blocks are representing the rate of new STIs, so sexually transmitted infections, that have been detected within our communities. And the communities are ranked by levels of deprivation. So the top block, the long one, is our most deprived communities. And then it goes down, second most deprived, third most deprived, fourth most deprived. And obviously, it is clear, and I've picked this deliberately because it tells a story, but I think it's one that needs to be demonstrated, is most deprived communities have double the rate of STIs detection now. We know largely why that is, and we know to a certain extent what we can do about it, but it's essential that this is recognised within the strategy and that our work is kind of targeted, that we channel our fire onto these areas and reduce the burden of ill health. So when we started putting the strategy together, we quite liked this top bit of text in bold there, because I think it captures the issue quite nicely from the World Health Organization, because it talks about sexual health being important to, you know, not just individuals and families, but this is essential to the social and economic development of communities. It impacts universally, because this is about people becoming ill for reasons that we can largely prevent and we can treat. So once we started the work, we followed a process which will of course be familiar when you're developing a strategy. We had stakeholder events. I'll say now that we were really pleased with the level of engagement that we got within those events. We had a nice wide range of people from the county, and we had it was pleasing to see the level of engagement and expertise that people demonstrated. This wasn't just people working within the sector; it was people working within related sectors. Had a good level of knowledge about this, and it was pleasing. We developed a steering group just to kind of keep us right. And everything we did, everything we wrote, we sound checked with that steering group. We launched a community survey, and the Sexual Health Service very kindly shared some of their own patient feedback that they collect as standard. And we had the second event in June to kind of round things off. So those are the priorities that we came up with, or the group came up with, really. So they're in the document that's in the paperwork, and it goes into a little bit more detail about some of the aims around how we would look to kind of deliver those. So those are the 4 priorities, and like I say, there's a number of cross-cutting themes, inequalities being one of them. So inequalities isn't explicitly mentioned within this, but if you look at the aims and the kind of actions we intend to take, it's clear from that. So outcomes, I think this is kind of what we want to achieve, and these are, I hope, are fairly universal that we'd like to see within services. We want service to be accessible to everyone, and they need to be accessible in a way that is appropriate for them. So we know that people will access information and services when they want to. So we have to be careful that those services are available and that information is up to date. In terms of what we can measure, those are standard indicators that are measured nationally, so we'd certainly want to see some improvement against those. Although I'm not here to give you an update around performance, I can say with some confidence that our treatment service actually does quite well against a lot of these. We've got a pretty effective treatment service. But as I say, the strategy isn't just about that service. And just to round off, I think I'm on time. Just to round off, just so people are aware of the next step. So we've got an action plan which is we're going to keep fairly kind of fluid, fairly kind of flexible, because we know that over the course of the 5 years of this strategy, things will need to be added to that, things will need to be changed. We don't want that strategy to simply be carved in stone. New things will emerge. A good example would be MPOX. So MPOX, of course, isn't solely a sexual health issue. It's far broader than that. It does have the potential to create quite a significant amount of harm to people. And that would have, certainly the sexual health sector would have a role in the prevention and the treatment of, in the event we had an MPOX outbreak. So we'll keep that action plan flexible. We'll maintain an expert group to oversee delivery, and we'll certainly make the request that we report back to this group on an annual basis to report on progress. And Chair, that's the presentation. Thank you.
Thank you very much. Very brief and informed presentation. Thank you very much. Are there any questions from the audience? Any suggestions? Yes. Jeff.
One thing I was intrigued with on your report was the statement, it hasn't got a page number, under the World Health Organization, about the one that's entitled Sexual Health is Fundamental to the Overall Health and Wellbeing, that page. And the statement below that was the one that I couldn't get my head around, was the ability of men and women to achieve sexual health and well-being depends on them living in an environment that affirms and promotes sexual health. I just don't understand that, because I don't think I live in an environment that promotes sexual health and affirms it, because I've never had that, and I can't understand what it's actually saying. Is it just a apple pie and, you know, is it just a saying? It does not really mean anything.
I think my interpretation of that is that sexual health, in my experience, is an area of our work within public health and within the work of other sectors of the health system, has a degree of stigma attached to it. I think sometimes conversations don't always come easily to individuals, and I include staff members in that as well, actually. It can be a difficult thing to discuss. And I think that's something that we need to look at closely, because if someone having perhaps an unwillingness to discuss their sexual health, or not being aware of how sexual health is treated within their communities, or where they can get information, or perhaps it's something that they perhaps should be ashamed of accessing, that can contribute to further ill health. It can contribute to people not wanting to access a service, not wanting to get treated. So I think my interpretation of that statement, that's where that's coming from, that we want sexual health to be something that is understood and comfortably discussed, rather than something that people perhaps feel a little bit uncomfortable, a little bit ashamed about.
Can I just follow up, Chair? The other thing I was thinking to myself, it's a really well-written and well-done programme here, which includes a bit we've just been talking about. But this is the sort of the thought of the programme. Do we actually have the people that we need to put this into effect? Do we actually have the people on the ground doing what we're doing? There's no point in just reporting. We need to fix it, in simple terms. But do we have the people?
Yeah, it's a good question. I agree. We can't just sit and report on. We actually have to do it. The stakeholder events we had were two times when I was personally got a lot of reassurance around that, to be honest, because, as I said earlier, they were well attended. There was lots of things going on that even myself and my colleague Claire, who lead on sexual health within public health, there was things that we weren't fully aware of, so it was a learning experience for us as well. The engagement was very high. You know, Do we have enough people? Does anyone? I would say that that will always be a question. What I'm confident of, though, is that the level of knowledge and commitment within the health system around sexual health was high, and I think that if we can help coordinate that in any way and improve it, then that's the aim of the strategy. But there is good work taking place, undoubtedly.
Yeah, if I can just amplify what John said there on the two questions, Jeff. First of all, if you think back to the 80s, and you might remember the HIV AIDS campaigns and the Tombstone and how badly that was received, because it absolutely created scare and worry and stigma, and actually the stigma then transfers into mental health issues for people who have got an infection, who are then scared to come forward, to be tested, to have the appropriate treatment that they are entitled to. So absolutely, as John says, this for us in relation to good sexual health is about part of that whole person, and being able to at the right time access services and know that you have the right to do so, and also be able to live a healthy long life, because the example that John gave in relation to chlamydia, what happens in your teens can impact you in your 20s, 30s and 40s. So if we don't get the messaging out for people to be aware of looking at themselves and also having the services available, then that can really not only impact physical health but mental health as well. And also just the second point around, do we have enough people in the system? Sexual health is part of our mandated function as the public health team, and the public health grant is our local authority responsibilities. But so whilst we do have that dedicated sexual health service, the way in which we can expand that is all predicated on the volume of public health grant we receive nationally. So there's always more to be done, but it's very much around how else do we spend that finite resource of the grant. But why this group is in particular important, in the slide that John highlighted, was this is a system responsibility. So all GPs, for example, need to be aware of what sexual health advice and guidance to give. Pharmacies need to 0 to 19 from a young person's perspective. So it's all of our responsibility to cascade our team's ability to talk about sexual health and either give that direct advice and guidance or be able to signpost effectively to the specific treatment services.
Thank you. Jill's touched on my question a little bit, and so did Jeff. What I would like to know is, John, if I'm a young person living in Berwick, for instance, and I know there's something wrong, where is my first port of call? Would I go to my GP? Or, would I go to, say, Berwick Infirmary? Where would someone go in a rural area?
Well, we would always recommend going to GP. Always, that's a fantastic place to start, and we would hope that would result in a diagnosis or a referral onto an appropriate service afterwards. If there was any reason why a person perhaps couldn't access a GP, I mean, for a young person or anyone for that matter, actually, we want information to be available essentially on your phone. That's where people are looking now for information for just about anything. You want to book a train ticket, you want to find information about sexual health, anything you want, it needs to be on your phone and it needs to be easy and accessible. I mean, our service, our commission service, has got a digital presence. They've got a pretty good website with a lot of really good information on there. And one of the things that we're working with them on at the moment is how we can further develop that, because these things don't stand still. It's something that you have to be kind of keep on top of. So that would be what we'd recommend first and foremost. And I would certainly, some of the feedback that we got from as part of the stakeholder engagement, young person services did talk a lot about the importance of digital and social media, and people were accessing a lot of information from that. So that would probably be my first call.
Thanks very much.
Thank you. Thanks, Wendy.
Hi, John. Thank you. I thought it was a really excellent presentation. I think there's three things just on my mind. One is the deprivation element of this, which is very stark. And from a public health perspective, I'm looking at the numbers. I'm not sure if there are any other conditions which are twice as likely to occur in the most deprived decile if we were looking at heart disease and other things like that. So I think there is a stark comparison there, which is useful to highlight. Looking at some of the numbers in the report, though, on the teenage pregnancy rates, you could interpret some of that in two ways. So we have about the same as the national average of teenage pregnancy rates. Our abortion rate, termination rate, is lower than the national average. Now, I could interpret that as being a good thing, because teenagers are supported not to, and they don't feel the need for termination, or I could interpret as a poor thing because there's a lack of access to terminations. So behind the numbers, you may know the answers to that, but I think we should just be careful when we're looking at reports like this that there are different ways of interpreting it. And then the access to long-acting reversible contraception. We have good access overall, but again, I suspect there are pockets of our population where traditionally we have had well-informed people who go and access that kind of contraception. So I would immediately think to the West Side, Hexham or Ponteland or Alnwick, maybe really good access. Some of our most deprived areas may not have the same access to long-acting contraception, so there might be variation in there that we need to dig on. I suspect you're doing that, but I just wanted to air it in public. Thank you.
You want to respond?
Just quickly, no, they're good points, to be honest, and certainly the one about data and statistics, yes. Yeah, it seems to be more pronounced within this part of health action that we do have to be very, very cautious about what interpretations we make around pregnancy is a good example, action termination. In terms of access, we are, as well as part of an early bit of work attached to the strategy, we're completing a health equity audit at the moment, and one of the things that's looking at is exactly that. Where do people access the service, and how does that stack up against the populations that we know are out there? There will be some obvious gaps come out as a result of that, and that's again the next piece of work that at least we know where we then need to target. Yeah, thank you.
Question slightly, Vice Chair touched upon that one. You put the statistics on STI and then matched it with the deprivation to say how it relates to our wider strategy of tackling inequalities. I mean, that's a good one. So I was looking at this under 18 pregnancy rates and other things. Is there such a correlation in that domain, on that metric? Like more pregnancies in most deprived areas? Is there something? So it would be nice to have a widespread metrics, a large number of metrics analyzed and then equated with tackling inequality, so we can look at it from that wider umbrella. So
there is a higher rate. You won't be surprised to hear. Perhaps a future piece of work to present to this group would be a focus purely on the inequalities impact on sexual health, because it is quite significant. Yes, absolutely do that though.
Yeah, then it comes to Graham's point about how we tackle the access variations within the most deprived and least deprived areas. Yeah, okay. So there are lots of things to do.
Just to add to that, Chair, it could well be of interest to the board to receive back the equity audit, which is exactly as John described. What is our current prevalence, and then then we overlay that against people, the services that are available. But for me, this strategy highlights an approach that is good practice, because we've got tackling inequalities throughout it, and this is creating a template and framework for us. So next year, when you receive the alcohol strategy, you will see it in a very similar format, because we are trying really hard to be system leaders in the way of looking at our within county inequalities, as well as comparators to the North East and to national. So your questions are absolutely right and proper, Chair, and we do need to work on our data collection to be able to evidence that, but there is very much deprivation association with all of the sexual health, including teenage pregnancies.
Thank you. So any other comments? Open to comments, suggestions? Yes, please.
Yes, thank you for the super report. I share Graham's concerns about the numbers and what they actually tell us. I just wonder, and it's great that you're tackling the access audit now, I just wondered whether the stakeholder events and your experience can shed any light on the user's experience of stigma, another potential barrier to access. Is there any insight you can share there?
Yes, we did. That was discussed. It's present in some of the kind of the feedback that we collected, and it was discussed at both events as a significant issue. There's quite a bit of work been done nationally around stigma and how it attaches and how it links to sexual health services. So it's mentioned within the strategy. I think is one of the cross-cutting themes, because we know it's a barrier to access. We know that it does cause people of all different ages to not access services, to not seek the right information. So it's a barrier to access service, and it's certainly something that has a direct link to people becoming increasingly ill as a result of sexual health. Yeah.
And it's well laid out in the document. Thank you for that. On your data point, Graham, it's interesting that we are struggling to get back to pre-COVID levels, not only in this but elsewhere as well. And I just wondered whether sort of changes in society since then have obviously impacted in that, but I don't know what we do. Great strategy, and I wish you the best of luck. And if there's anything we can do from the Health Watch perspective to help with the communication, then we're happy to do so.
Thank you.
We've got a journey to go on, haven't we?
Thank you. If there is no other, let me thank John Liddle. Thank you very much for the report. I think we have formulated the strategy. There are lots of things to work on. Look at the methods of managing how we do that. Thank you. And the second item is the annual report by Principal Social Worker. It will be introduced by Wendy Patterson.
Thank you very much, Chair. And I'm delighted, actually, just to introduce beside me is our Principal Social Worker, Tracy Horseman. And on my left is Karen Martin, who is our deputy to Neil Bradley, who is our Executive Director. And so without further ado, I just want to say how immensely proud I am of our social work team. We work very closely and interlink with our regional universities, and so we're in a position to speak to leavers of university and find out what area or what branch of social work interests them. And from there, we're able to recruit, and they come into Northumberland County Council and enter our social work academy, where they're mentored and, if you like, supported for a year before they go finally into the world, so to speak, on their own. So it's just a real pleasure for me to introduce Tracy to you, who's going to take us through the report.
I am, yes.
So, Tracy, everybody.
Yeah, Karen's going to go first.
As Karen, sorry, Karen, go. Karen's going first.
Okay, I just wanted to start really to emphasise that the principal social worker in adult social care, it is a statutory requirement for a local authority, and that can vary in breadth and seniority. But in Northumberland County Council Adult Social Care, our principal social worker is very much part of our senior management team. And the reason we want that to be is that she is very much part of the strategic planning in adult social care, and she can link that to quality and practice for social workers, our social workers on the front line that absolutely best support the people the vulnerable people we serve in Northumberland. With Neil and I being fairly new to the role of exec and service director, we were very keen to share the annual report. So Tracy's going to talk us through the annual report, the achievements, the challenges that we've had, and certainly talk about some of the forward planning. So I'm going to hand over to Tracy now.
Thank you. Nice introduction. Thank you very much. Thanks very much for giving us the opportunity really to come along and talk about the annual report. I know Wendy's talked about being, very proud of the social workers and the social workers that we have in Northumberland, but I would say equally I'm really proud to have this role. It's a really key role in terms of social work, and it's a really key role for adult social workers as well. hopefully you've had a chance to have a look at the report. What I'm going to do, I've got a little presentation, and I'm just going to share a little bit of the flavour of the report. So I'm not going to go through the whole report. I just want to kind of give you a nice flavour of some of the key aspects, really, of the report. What's really interesting is, and I always struggle a little bit with this, because it's last year's report, you might find that I fall into a little bit about talking about kind of this year as well. But obviously, because it is last year, it's thinking about how far we've developed in a year as well. So the three kind of main areas that I identified on the report are around the three key priorities really for the PSW in adults. Very much about quality in practice, and my role is very much absorbed around ensuring that the quality is there around social work practice, and obviously quite clearly ensuring that social workers have a good understanding of, and I talk a lot about what good looks like. You could say what excellent looks like, but actually, you know, you can't achieve those standards if people aren't clear about what are the expectations for those standards. So quality and practice is a really kind of fundamental part of the PSW role. Leadership and learning, it's very much, and when CQC came in, they talked about, you know, is the PSW visible? Can people see, you know, do they know who I am? Do they know, you know, who to go to in Northumberland? Do the social workers know who to approach? So that leadership role, that role model and that mentoring in terms of good social work practice, again, is fundamental. And workforce planning, and we know that nationally, so it isn't specific to Northumberland, we know nationally that we have some recruitment issues around experienced social workers in particular. So we've just recently set up a workforce steering group for adult services to look at a lot of those issues as well. So again, focusing on, you know, the number of social workers that we need, and not just the number, but the differences in the team in terms of making sure we've got a good ratio between newly qualified social workers and experienced social workers is really important. So I'm just going to cover three areas really in the report, again just to highlight our achievements, and I know Wendy's talked about the Academy, but the reason why, for lots of reasons why we want to talk about the Academy, it probably is one of the few, there's a lot of children's social work academies, but our academy is one of the few adult social work academies. Not a lot of people have set them up in the adult world, and I keep thinking I'm sure it's the only one, but I don't want to say that completely in case I'm wrong, so I always err on the side of caution and say it's one of a few adult social work academies. It is very much our recruitment and retention flagship. Very much what we know about is if you look after people, you know, in their first year of practice, if you give them a good experience, they're more likely to stay with us. Before the assessed and supported year in employment was introduced, which the newly qualified social workers go through, we knew that people were leaving in their first year of practice because what was happening is sometimes that they were not, you know, were given caseloads that were, you know, weren't sustainable. So in the academy, we've got very clear capped caseloads. We've got a really good package of reflective supervision for our newly qualified, and we've got protected time for their learning and development. And we know that is about, we can retain our social work staff as a consequence of that. And those newly qualified staff are going to go through and be our experienced staff in the future as well. Obviously, it was set up for our newly qualified social workers, and it is about providing that real high-quality learning environment, so people feel safe, they feel supported, and I always believe that if you're supported, you feel like you can take on, you know, work that you feel comfortable and confident with. We have 3 team managers in the academy, and I've used the word nurture, and I think that's a really important word because it is about nurturing people into this profession. So again, you know, it's about nurturing and introducing them to the challenges that sometimes come along with, you know, social work cases and social work practice. So I'm really keen, it is about nurturing people so that they can develop, and they can develop their confidence. We've expanded really the remit of the social work academy. The induction that we provide for all of our newly qualified social workers is incredibly robust, and what we've realised is actually all of our new staff that come into Northumberland should actually go through this induction as well. And again, we know that induction, again, if you get a good experience at the beginning of your career, again, we know that that will keep you and make you want to really stay in Northumberland. Very much about, you know, that we're clearly seeing the benefits. We've had the Academy in place now since 2022. And again, in my role, I'm involved in a lot of auditing, and you can clearly see the benefits of the work that the newly qualified newly qualified staff even are producing when I'm doing the audits. You can clearly see that that is high quality work, and I think that's really important. So we're starting to see the impact really of the Academy, and you know, that consistency that we do provide in the Academy for newly qualified social workers. Just going to talk a little bit about the audit framework, because a lot of my role is about auditing case files, looking at social work practice, and we've got a clear audit framework in place. We've had it in place since 2022 even. We've reviewed it and we need to review it again, but it does very much give us that clear structure around audits. We've got a number of different audits. We've got our case file audits, which I've talked about, but we have some themed audits. So if we want to look at a particular area of practice, we've just done a themed audit around transition cases, moving from children to adults. And we also carry out a lot of audits within our internal assurance visits. And our internal assurance visits are very much, and I describe them as almost little mini inspections when we go into teams and we look at kind of how things are developing in teams. So we carry out some very specific audits within those internal assurance visits as well. What we want though, it's like anything, we want staff to feel comfortable with the audit process. We want them to feel, because if they feel comfortable with it, we know that they'll develop, they'll learn. And we also know that if they're comfortable with it, it's an experience that they'll embrace. It is very much about being accountable as a social worker, and it is very much about, you know, your work, you know, is open to scrutiny for lots of different reasons, but it is that supportive practice, and it is trying to get, as I said, trying to get people to feel comfortable with it. Very much, and I've said this already, it is about for staff to understand what good looks like. They need to know where we're working to for them to achieve it. So I've used good, it could be excellent. And we want staff to learn and develop from that audit feedback. So again, that audit feedback goes back to those staff, and again, they learn and develop from that audit feedback. And I'm just going to talk a little bit about the People's Advisory Panel as well. We just set it up in November 2023. It's very much, I think, a reflection of the way that we want to work in Northumberland. It's very much about that collaboration. It's very much about that co-production of making sure that we're involving people with lived experience, because I might have a view as a PSW, Karen might have a view as service director, but actually we need to go to the people themselves to keep us almost, you know, online in terms of, actually, have we got this right? Are we doing this right? Does this feel right? And I think that's really, really important. So we've got 6 resident advisors on the People's Advisory Panel. We're hoping to increase that. It's chaired independently. It's chaired by Health Watch, so it's chaired by Derry Nugent. And those people, those resident advisors, are people with lived experience. They are carers as well. And they've really supported us in looking at a lot of the work that we're doing. So they helped us and supported us in terms of looking at our self-assessment documentation that we submitted for CQC. They gave us a really good viewpoint on that and some really good tips in terms of how they would change it and frame it slightly different. Our website, it's been really important that, again, people who are going to use our website are actually giving us direct feedback about, is it user-friendly, is it, is it working? Basically, does it work for them? And I guess the big part, I'm really pleased with that, with this part in particular, is they've helped us rewrite and reframe our carers assessment training that we present to frontline social workers, and they co-facilitate it as well. And that's so important, again, for the social workers to hear about what the real life experiences are of being a carer. So, you know, as a facilitator, we can talk about it, but there's nothing, you know, there's nothing better than hearing what it's really, really like. And, you know, that will resonate with social workers and resonate with their practice. And just kind of looking forward, because it's always looking forward, isn't it? You kind of, I'm kind of writing the next annual report as we speak, so it is kind of looking forward. We've done a lot of work around, and I know this is already in place in children's, but our advanced practitioner role, and that's a role that will sit between our social workers now team manager, and that's a really, really important role in terms of people for their career progression and their career framework. And again, we know that career frameworks and career pathways is what keeps people in the role. It's what they, people are looking to. What can I develop? Where can I go? What can I do next? So our advanced practitioner role is really key for that. Our case reflection tool, I talked about in the report that we piloted that in a number of teams, and that is fundamental really for social work practice, that we provide very good quality supervision for our social workers, because again that supports them in the practice, that helps them to really have a look at what's happening for particular people, and how again we can improve our practice. So that case reflection tool is going to be rolled out across all of the teams. And again, we're always looking at and heavily involved both regionally and kind of locally in, because again our North East colleagues have exactly the same issues about how do we recruit experienced social workers, how do we ensure that we've got that real rich element of experienced social workers who can support our newly qualified social workers and help develop them and help mentor them. And that's it.
Thank you very much, Tracy. Thank you. It was a very good report. Thank you. It's the first one, isn't it?
It is,
the
yes.
first time.
Yeah.
Yes. Okay, good.
Yeah.
Are there any questions? Yes, please, from the back, very back.
Hi, that's so interesting, and it's such an important work that you're doing. It's really great to hear. I just wondered what your thoughts were and what work was happening about trying to increase participation, particularly from a sort of wider group, particularly across inequalities. That whole lived experience is so important in the work that you're doing. And obviously degrees and I know it's very, very highly, the qualifications are exceptionally high. I just wondered about kind of advanced apprenticeships from a local authority perspective, and if that work of the academy could be almost reached further into communities to try and encourage a wider participation from different communities.
Yeah, absolutely. It's a really good question, because you're absolutely right. At the moment, that kind of emphasis on newly qualified. We do have our social work apprentices in the academy as well. So we have staff that we... it's very much about you grow your own model, if I'm honest with you. So staff who don't hold a social work qualification, who may work for us as a social work assistant or a care manager, and actually don't have, haven't had the opportunity to go to university to become a social worker. So we have that scheme in place whereby we support our internal staff if they've got the appropriate level of qualification to then develop to become a social worker, and we work in conjunction with Sunderland University around that as well. So we've got the social work apprentices, but the other work that we're doing at the moment, because I do get your point in terms of kind of wider, is we're linking up. We've just appointed a new manager of the Care Academy, so we're linking up with our Care Academy and looking at what would be the career pathways for some of our frontline carers who will be supported by the Care Academy, but later on in life may want to go through the social work apprenticeship and may want to, develop to become a social worker. So it is kind of going out that little bit wider. And I think I always see the kind of academy as it's only going to get bigger, really, in some respects.
That's really helpful. Thanks. I think I'm looking more about the Grow Your Own is amazing, but it's more about kids coming out of school, and it's that we're seeing increasing numbers doing. NVQ Health and Social Care. My own daughter's doing that at level, dual award level 3. And it's how do we tap into those, because what we're at risk of doing is losing them to the NHS, because the NHS has multiple pathways for those children to go into the Northumbria Academy and be a nurse practitioner route and things like that. And that's really what I'm trying to make sure that there's a parity, because both roles are equally important.
With the council, and hopefully your next report will be even better next year. So thanks for that.
No? I just want, sorry, Neil, please, yeah.
Thank you, Chair. Yeah, I mean, just a comment from me. I mean, obviously, I'm tremendously proud of the work that Tracy and Karen do in this area around driving up quality. And I think there's two key points that have been touched on as we've gone through, but one being the inspection regime that's now sitting over adult social care sees this role as absolutely critical. I mean, I was actually quite surprised when the inspectors came on site and you were one of the early sessions, Tracy, with the inspectors, just how much emphasis they were putting on the PSW at that point. It was more than I expected at that stage, even though clearly the quality of assessment is at the forefront of the inspection process of what they're trying to achieve. And although we haven't had our outcome yet from the CQC assessment, we're expecting that hopefully in a few weeks' time, the early feedback we got, both directly from the interviews that were held and from the high-level feedback I got verbally at the end, was they were really impressed with the structure we had here in Northumberland. They were impressed at the level of responsibility that Tracy particularly had as the individual in the organisation, and that she was a voice that was listened to in the senior leadership team. So that was really good. I think Karen and I have both been keen. I mean, you don't have to produce one of these reports. Although the PSW is a statutory requirement, the report isn't. But when we've swept the country and had a look, high-performing authorities in this area do produce this sort of feedback, so that boards like the Health and Wellbeing Board, and we will look to take this to OSC as well, can have a critical look at how we're trying to deliver quality and drive up that quality going forward. But the key punchline here is we are in an absolute bun fight for staff. There are not enough qualified social workers in the country. There aren't enough qualified social workers in the North East, and we want an excellent reputation to hold on to our staff. And this report, this service, what Tracy does, what Karen does, is critical in delivering that. And I think we're starting to get it right, is my honest view here at the minute. The Academy, I mean, we had some external critique of the Academy from Skills for Care, didn't we, about 14 months ago, and they described it as one of the best models they'd seen as they were going around the country, and verbal feedback that we had there as well. And we just need to keep this ball rolling at the minute, because, as I say, if we don't, the people in Northumberland will lose out, because we'll lose good quality social workers. Thank you.
Retention is very important, and training is also very important. In fact, I just have a very minor question. It could be slightly off topic. You know, when I was preparing for CQC inspection, first of its kind, so I was going through all the reports, and there are lots of vacancies we were unable to fill in. And also, I sit in the OSC in NENC, Northeast and North Company, is a bigger region-wide, this one. There also they were expressing concerns. It's not just Northumberland. So I just want to know, in that sense, the Academy is a fantastic idea, and it's just great. I just want to know how we are addressing, what is the vacancy? Is it getting filled up? You are improving, or are we making some progress on that one? Because the information I had was about at least 9 months old. So if you could share some information on that one, it'll be even informal one.
Do you want to come back on that, Karen, since it's your service area?
In terms of vacancies for social workers, what we're doing, a lot of them are newly qualified social workers.
Yeah.
And it is a case of we just need to keep that balance right, because they can only work, they've got capped caseloads, they can only work to a certain level, and they need to kind of go through a professional development. So it is really key about getting that recruitment and get that incentive to come to Northumberland, and getting out there and talking to the universities. You know, Abby picks up on a good point about getting out and talking to the schools before people go to university. So it's getting that message out there. And literally, we do know from the interest that we're having newly qualified social workers that the universities have really thought, oh, Northumberland have got a good programme here. So it's a challenge, but we're doing, you know, we're certainly doing our best around it.
Are there any questions, any suggestions, remarks? Okay, so in that case, let me thank you all for having a good presentation and the discussion after that. So we then now move to item number 6, Children and Young People Service. There's an update from the service. I'm sorry?
Paul, can
Oh, sorry, Mark. Yeah. Okay, I didn't realize you pressed the button. Yeah. Yes, you work in CNTW. That's right. Yeah. So you want to declare an interest officially? Yeah. Okay. So this will be introduced by Vice Chair. Can I ask you to go ahead?
Thank you, Chair. This would have been Veronica introducing this, so I've been thinking here how to channel some inner Veronica. In a minute, we're going to hear from Michelle and Katie, and Kath from CNTW is here as well. We've got Chloe in the room, and we have somebody else from CNTW in the room. My first perspective on this is if a family requires support from the Children's and Young Persons Mental Health Service, if we did a Venn diagram, I suspect there's an awful lot of those families are also touching either looked after children, safeguarding, SEND, their GP, the school. So this isn't something that we can take in isolation for the vast majority of families. And also, if you are a family looking out, I think it can be a bewildering jigsaw of services that you may have to navigate to find the place where you feel that you are being listened to and having your needs met. We've also got 0 to 19 in the room. These families will be known to you, probably the voluntary sector. So it's a real thing about interagency working for me, okay? And actually trying to help families understand who is the person, where does the help come from, because families like this are often suffering a huge amount of stress. They're feeling, often the background is of a bit of mayhem, feeling like they're not coping properly, maybe some guilt, maybe they don't like to feel that they're not coping. So it's a really difficult place for families to be. So our job is to try and make it as easy as we possibly can for them to get the help that they need. So that's my inner Veronica. My bit about focus, though, is that whenever I see something come to Health and Wellbeing Board, I always try and think, well, where does this fit in our joint and health and wellbeing strategy? And I'm trying to get in the habit. If I need the paper version, Jill, please, and I would say maybe we need another pile of them for everybody to take, because actually it's much simpler to pull it off the shelf and look to see which chapter and which bit, and actually what are our outcomes that we were looking for here. And on this one, we're sitting squarely in the starting and growing up well element of it. And then if we look at priority 3, that says supporting children and young people's physical and emotional well-being. And then if we go to that bit, there's 2 bits in it. One it says, we will work in partnership and link with community assets to provide effective prevention and early intervention opportunities to support the development of children and young people, including the Growing Healthy Northumberland 0 to 9 service and family hubs. So there's something there about us all working together. There's actually a paragraph underneath it that says tackle inequalities experience. So we just need to make sure we think about that when we listen here. And then the last paragraph is improve the experiences of children and young people in relation to their health by developing the knowledge, skills and capability of workforces through partnership and integrated working. And actually this room is about partnership and integrated working. So that's where I think when we listen, we need to think about that. And then what would be our outcome on this? The outcome is actually listening to children and young people and their families, including case studies from those involved in community strengths-based opportunities and using services. So that's where we want to see the outcomes. And with no more further ado, I'll hand over. Thank you.
Good morning. I'm Michelle Bolelli. I'm one of the clinical managers within Northumberland SIPS. I oversee the mental health and learning disability pathways, and my colleague...
Hi, I'm Katie Paul, and I'm clinical manager within the neurodevelopmental part of Northumberland SIPS. And I just want to mention we don't normally wear yellow like this for work, but it's World Mental Health Day today, and as a service we're supporting young minds. So there's, I think, nearly 100 odd staff wearing yellow today. So I just thought it would be nice to mention that.
Yes, yellow's not my colour. Oh, thank you. So we actually, just to follow on, I think that the important thing to get across today is we are SIPS, formerly known as CAMS. We are part of the bigger jigsaw. So we'll start off thinking about that system, which is absolutely can be very difficult to navigate. So several years ago, probably going back to 2017-18, Northumberland as a whole emotional and mental health offer of Northumberland adopted the Thrive model. So we all came together as services from our voluntary sector, SIPs, the primary mental health, our 0 to 19 colleagues, everybody that offered anything remotely involving children's emotional and mental health well-being. We all came together and we mapped out our services against a needs-led. So we moved away from medicalisation, diagnostic criteria, and thought about what is the young person's needs and who are best to meet those. Where a majority of all our services is very much in the preventative and looking at the family hubs, the early help model. So that's where most of our colleagues sit. And as you'll be able to see, this is the Thrive model. And SIPs very much sit in the getting more help. So we're kind of the tip of the iceberg, if you like. And we have our colleagues in the family hubs, in the coping, getting help. But what's really important to kind of emphasise here is we actually sit in all of them. So we are, you know, very much have a seat around the table. We interface on a regular basis. We know each other by first name. We can kind of pick up the phone and join a Teams. So we are on a weekly basis interacting with all of our partner agencies within that Thrive model. So I'm hoping as time goes by, we will start thinking about kind of we work from a no wrong door policy. So if a parent or, you know, a professional, GP, anybody refers to us or picks up the phone to us, we will get the referral to where it needs to be. So it wouldn't be a case of asking another professional or a family member to navigate this quite difficult system. We would do that on their behalf.
And probably about 2 years ago, I would say, the neurodevelopmental pathway, which is a challenge, you know, it's a national challenge assessment for autism and ADHD. We were asked by the ICB to slightly lower the threshold for assessing those children and young people, but we obviously can't meet all of the needs of those children and young people. So we then agreed that we would assess children where there is a clinical impact on their functioning. So it's not kind of just because I want to find out, is there something going on, but actually they're struggling at school, they're struggling at home. And actually, so we now assess those young people and they sit around that Thrive model. So that means that a young person may be referred to our service and we accept them for an assessment of autism. However, they might have some unmet need. That unmet need doesn't need to sit with a specialist mental health service. That unmet need might need to be sitting in the 0 to 19 service. It might be with our primary mental health colleagues. It might be with the voluntary sector, because actually that diagnosis, however long that might take to receive that diagnosis, is not going to change the need of that child at that moment in time. So we're very much signed up to that, and that's the way that we need to kind of move forward, and we'll talk a little bit more about that. I think around this whole system, as Michelle's alluded to, how we work with our colleagues in children's social care, education, parents and carers, and everyone. It's like this is a national issue. All of the pressures around children's emotional and mental health and autism and ADHD is everyone's business, and it's not just us to be able to fix this problem. So how it's really important that we work together. So Michelle, do you want to talk about what we offer?
So CNTW, thinking about that, the specialist mental health provision that we offer, we are kind of the higher end of the graduated response in the Thrive model. So we often see young people and children with a significant mental health impact. What we aren't asking others to do, because I know that can be quite difficult, is for you to deem, or a parent to deem, is it significant impact? So again, wherever that phone call comes, we will just determine with our colleagues from a clinical perspective. So we offer the high end of that getting more help, that specialist mental health provision. The service works closely with the partner agencies, and we operate in line with the wrong door, as I previously kind of discussed. And we operate as 3 teams within under one umbrella. So we have the mental health pathway, learning disability pathway, we have the neurodevelopmental assessment pathway, and actually there's an ADHD monitoring team also. So, sorry, Kay.
So what we aim to do is thorough assessment and formulation and provide diagnosis of a range of moderate to severe mental health presentations. We always use evidence-based, every intervention we use is evidence-based and it's goal-orientated. We'll work with the child and the family right at the beginning. What do you want to achieve? And actually sometimes we might never hit 10 out of 10, but actually it might be 7, it might be 8, and that might be good enough because our lives change all of the time, and it's about giving the young people strategies to be able to help navigate through the rest of their life. Everything we do is where families and carers are at the centre of everything we do, and actually more recently we've really embraced participation. We've got one of our members of staff that leads participation, engaging with families and young people, and more recently we've employed a parent carer, peer support worker within the neurodevelopmental pathway to support those parents whilst receiving an assessment. Care and treatment is delivered by a multidisciplinary team, so we have every discipline from psychiatry, occupational therapists, nurses, psychologists, art therapists. I'm probably going to miss somebody off there. But yeah, and everyone works together, and that's what makes us special, I kind of think, because we have to use everyone's skills to help these young people. For the young people that are open to us at the point of transition, so we consider transition from 17 and a half. So at 17 and a half, what will that child need in the future for their emotional and mental health support, and ensuring that we have a robust plan in place for that. We also provide a lot of mental health training, consultation, support and advice. It's not uncommon for GPs to ring us and we'll have a telephone call with them and say, would you like us to come out? And, you know, we'll go out and do a talk, and sometimes just dispel a lot of myths that are about us. I think a lot of things I talked about that might be 15 years ago, and that information's incorrect. And the other thing I think we do really well is our interface with partner agencies. I'll go on to talk about referrals and demand. So I think you can see the referral data coming into our service since kind of COVID. It's going through the roof. And our workforce has not changed to meet the demand of this. What we would say when Michelle and I talked about this presentation was, I do think a lot of this is around referrals for seeking a diagnosis of autism and ADHD. I think we've got that emotional mental health graduated response pretty perfect, if I'm honest with you, about making sure kids get to the right place. It's about that element of seeking a diagnosis. And actually, on the first telephone call, we don't always have the right information, so that referral is then closed. It creates another referral. And actually, that's a piece of work we'll talk about later on in the presentation that we want to work on next. My goodness, the numbers are staggering. You know, in 2019-20, we received 1,867 referrals. Last financial year, we received 4,772 referrals. Each of those referrals all have to be processed, you know, and even just to date for this year, we've nearly matched what we had back in 2019-20. We can see that the average acceptance, you know, has declined, but we feel that's around these referrals that we haven't got all the information around when it comes to autism and ADHD. So that's ongoing work we need to do with our partner agencies and the ICB, and that bit of work's ongoing. So, do you want to talk about this bit, Michelle?
As Kate has touched on, the referrals and the demand and capacity, it does have an impact on workforce. The staggering numbers of referrals didn't come with any more capacity within our service. In fact, very similar to our social worker colleagues, we've struggled to recruit experienced, what we would call good old-fashioned CAMHS clinicians, because it's not just them newly qualified, it's the experience that we need as well. Let's get off the screen. We experience recruitment challenges, which is across nationally, can't get my words out. The complexity of young children, children and young people, has increased significantly. We're still kind of trying to work out if we are seeing young people later, and is that why they're kind of presenting with such complex needs, or is it the way of the world and how, you know, we've evolved as a social media, and it's very much mental health is, everybody's very aware of mental health now. Is it because of, you know, the advertisement of it all, almost, that we are seeing young people with such complex needs? But that has also changed the approach that we have to take. We're partner agencies in the Norton 19 team. That's impacting what also we've had to very quickly match our skill set, our experience, you know, and think about how we can meet those challenges coming through the door. And that's still ongoing. During COVID, it was, we're still living with the impact, is a lot of services kind of stepped down. We didn't. As a specialist mental health service, we were still out and about. We thought actually it was more crucial that we were out and about more than ever. But it became quite difficult because we had nowhere else to go for young people. We had nowhere else to signpost young people. So we ended up, you know, holding young people that maybe ordinarily wouldn't have sat with us. So again, I think that kind of, because we've offered a inconsistent approach, often that's why external agencies will kind of feel that we are inconsistent with our criterias or thresholds. And I think it's just because we've adapted as the years have gone by to what's been required at the time. Risk thresholds, again, I think these have very much changed as services came out of COVID and the world adapted to a new world. The risk thresholds very much changed. You know, I think it was only last week we were having a conversation with colleagues in Northumbria and A&E in regards to what we would categorise as an overdose to what A&E doctors would. So again, there's still a lot of work to be done. Receiving the correct information at the point of referral for the neurodevelopmental assessments Katie's touched on there. And we have got a little bit of a way around that, because what we want to hear is information in regards to the children and young people from those that know the young person best. And often that is parents, we're professionals in our own children, and schools. You know, that 7 hours a day they're in school, they're being observed, and they are the best people to tell us what, you know, the difficulties this child is presenting with and what the help and need is. So we're moving very much to where we're gathering information. It will be mainly from those two environments, from a neurodevelopmental perspective. One of the things that we didn't capture earlier is one of the things we often measure ourselves, and I keep pointing to Sam from the Norton 19 team, because they have these conversations quite often, is we'll know we're getting it right when the high end, being us, from a children and young people's service, specialist mental health service, when we are receiving the least amount of referrals in comparison to our colleagues across the early intervention and the preventative services. We'll know they're working when we're getting the least referrals. And I think we've still got a little way to go, but we're kind of moving away. But at the moment, if we look at the whole graduated response and the Thrive model, SIPs at the moment are still sitting with the majority rather than minority. So there is some work to do, but I think we're definitely not far from it from a mental health and learning disability perspective. I think that very much differs from the neurodevelopmental assessments. That's kind of rocketed.
So we touched on right at the beginning around kind of how we interface with other services, and I think every professional and every service that works with children and young people, all we want is to ensure children's needs are met by the most appropriate service at the most appropriate time. We don't want to be getting referrals that say, little Johnny's had low mood for 2 years, can you help? Well, what happened 2 years ago? That should have been when we were intervening. So that's why it's really important that we interface with other services, and there's so many more. But on here we have bookable daily consultation lines for advice and referrals. and that's delivered Monday to Friday, 9 till 5, and that's about 45 minutes with a mental health clinician where parents or professionals can just come and talk for advice. If we feel that's a referral for us at that point, that information's taken and that is the referral opened. It may be that actually we feel it could be for our colleagues in the 0 to 19 service or the voluntary sector or colleagues in primary mental health. We will get that to the right place. We interface internally within CNTW with our colleagues in the Universal Crisis Team, children's eating disorders, inpatients. The next kind of step up on our mental health pathway would, for some young people, a minority may be hospital. But actually I think we have a really good response time in Northumberland. The waiting times to access mental health support is about a week. And that has been consistent for probably the last 3-4 years. That has been consistent. So if a child needs that mental health support from us, that's how quickly they receive it. We interface with our colleagues in the primary mental health service and the 0 to 19 service weekly. So we might send an email over and say, could you consider this one? If they could, sometimes they'll respond and go, that's great, yes, we'll take them. But sometimes we might all have a bit of information about a family and we really need to understand the bigger picture. So we will meet on a weekly basis and discuss those young people. We attend the Children Missing Education panel monthly. We engage with the family hubs. We have got a matron for a lead for SEND and how we support the SEND agenda. We are part of the Cramlington and Blythe Youth Vol, which is around criminality and antisocial behaviour and sharing intelligence. Early help, children's social care, the inclusion panel, which is around children where schools not being able to meet their needs anymore and they're looking for an alternative provision and how can we support in that system. And then learning disability nurses run termly consultations into the special schools directly with those staff. And as I say, there's so many more. So our achievements over the, me and Michelle might both chip in on this one. So our achievements over the last few years. So we were really so proud, I would say, to receive a 4-week wait pilot site for NHS England. We were one of 12 across England, and that came with a proportion of money to support that. But actually, what I think is really important to share is we never filled all our vacancies. So actually, we achieved this with never the full workforce that NHS England wanted us to have. And actually, we were the only area, I also believe, that put the neurodevelopmental pathway and CAMS, if you like, into the same pilot. We were the only one in the country. And actually at the end of the pilot, which kind of coincided with COVID, the neurodevelopmental pathway was hitting a 6-week wait for assessment to start. COVID then happened and challenges came. And actually from that, we've got monthly contact with teams around the country where we support them around how to change their way of work and their practice around referral and access and time-limited intervention and having positive outcomes for children and young people. So I think that's something as a service we're really proud of.
Sorry, we're also the only service nationally that part of the 4-week pilot we see young people face-to-face for their very first appointment, and they're into treatment within 4 weeks. So all young people from a mental health and learning disabilities perspective have 2 appointments face-to-face within 4 weeks, and we were the only ones to achieve that because a lot of other kind of services were, and you know, they kind of done it through telephone triage for their first appointment, but we thought it was really crucial to keep that element of face-to-face going.
Actually, with our feedback from COVID, when we did have an element of online, actually what the kids were telling us is they don't like online. You know, they love FaceTime, they love social media, they love doing all that. But when it comes to talking about themselves and talking about how they feel, they really want to be with something. So I think that's something we feel really passionate about, is making sure that we continued with face-to-face. Skilling up our workforce to meet the ever-changing demands. You know, Michelle and our careers have been in this area, and what we were seeing 15 years ago to seeing now is very different. And actually, people come and tell us their diagnosis, and I'm like, no, we need to change this kind of, the way people are talking about it. You know, you're not depressed, you're a bit sad, and it's trying to kind of, you know, it's up to a specialist service to give a decision whether you meet a diagnostic kind of criteria for something. So yeah, it's ever changing, and I think having a really strong workforce plan helps us to keep up with meeting the demands. A lot of training for staff around trauma has been really important over the last few years, hasn't it? And we can see that's something that's grown. As I've already mentioned, wait times across pathways in the mental health and learning disability, as Michelle's already mentioned, one week, and then 2 weeks to 4 weeks for the second appointment. Actually, within the neurodevelopmental pathway, I always kind of get a bit worried when I talk about this, but we actually see children for something called a welcome event within 4 weeks. We meet the parents in a group setting within the family hubs, and that's about giving advice on where to access support whilst you're on the pathway, because a diagnosis is not going to change the needs of the child right there and then. And our wait time is 12 months for an assessment to start from the point of referral, but actually if you look at that nationally for an NHS service, it's still pretty good, and actually ensuring that children and young people are getting their needs met whilst they're on that pathway is something really important. We have implemented a parent carer peer support worker to work alongside the families within the neurodevelopmental assessment pathway. And actually, over the last few years, we've been nominated for Clinical Team of the Year within CNTW, so our organisation, which, you know, is just... that's down all of the team. Every person that works in our service just has kids at the centre, from the receptionist that meets them at the front door to the clinicians that they work with. We've had the implementation of the welcome event within the neurodevelopmental assessment pathway, and as I've already mentioned, they're delivered in the family hub. And I think, you know, the feedback, we've just done a bit of research. We've seen 1,000 families through those welcome events, and about 98% of families have felt that they've been so helpful, and the miscommunication families have had about they need a diagnosis to access support, actually us dispelling those myths has made an absolute difference to those families. And actually now we are able to see which families are actually accessing the 0 to 19 service, accessing primary mental health, the voluntary sector, having an early help family worker whilst they're on the pathway for an assessment. So some of the challenges, do you want to talk about the challenges?
Yeah. Sorry. Along with, I'm sure, lots of our health colleagues, children not being brought to appointments has a huge impact on our waits, because it doesn't reset the wait time, you know, that it kind of continues. So if a young person isn't brought to their appointment 3 times, we still have to meet that 4-week wait. So, you know, we do have our own challenges. School holidays, miraculously, lots of children don't want to come to see us during the school holidays. Often they're going off on holiday with their own parents, or they're out socialising with their friends, or actually they're just feeling better because a significant pressure has been removed off them, and their anxiety has reduced during the school holidays. Sickness and vacancies, again, I suppose that's across the board, again, with all our colleagues. We do have, you know, clinicians that will go long-term sick. We do aim to reallocate the young person within 4 weeks to another clinician, maybe a little bit longer. Often that's because we're trying to wait for the clinician with the right skill set to meet the needs. But we always keep in contact with the families and let them know where we're at. Vacancies, as we've touched on, huge increase in referrals. The culture of medicalising and diagnosing to access help, Katie's touched on that. I think it's really important that as a system as a whole, that we start to think about changing the narrative around children's needs and thinking about, rather than the diagnosis and medicalisation, thinking about what is the child's needs and what can we do about it as a system. Changing the thresholds from other services, and again that all comes with monies and funding, and you know, and the way of the world. I think the world looks very different now as it did 15 years ago, and often as a service we have to transform and continually to develop to meet the children's needs at the time. And that can be really difficult, because it can be, you know, what our threshold is now isn't what it was 5 years ago, but nor is children's presenting needs. Maintaining how services perform, we're in. It's really, really difficult, isn't it? We all get together and we all have very, very similar difficulties across the board in services, but what we're doing very well of is coming together and thinking about it, not just from a CNTW perspective, a Northumbria perspective. We're getting in the room and we're having these conversations of how we can help each other and work together. The need for children, the needs of children, young people become more complex, and probably our biggest challenge yet is managing parent and carer expectations. That is a rather difficult one that, again, I'm sure lots of our health colleagues feel that on a daily basis. We are absolutely, you have a very stressed out mum, you have a very stressed out dad, and at that time they are in the midst of their crisis. And for us to come along and say, that may be a crisis to you, it isn't so much to us, is probably, you know, how we, again, change our narrative and communicate and work with parents to ensure that Northumberland and Children Young People Service, as in SIPS, we are not the golden ticket and we can't do it all. But what we do is we work in a system of a number of our very skilled clinicians that can also offer the same at the level that they need. And it just allows us all to be able to do what we need to be doing for the children at the time. But managing a parent's expectations is rather difficult and challenging at times for us all. But again, I think if we do it together, it kind of, and give a consistent message, we'll get there in the end.
So our next steps. So we've been having discussions with the ICB, but also within our organisation as a whole. There's been lots of transformation work going on around children and young people's mental health, but also the neurodevelopmental pathway, assessment pathway. So some of the changes, I think one of the challenges is having a name called Northumberland SIPS. What does that mean? To me, that means we'll just do everything. And actually, we just had a parent recently that says, oh, I'm not in CAMHS. Well, yeah, you are in CAMHS, but it's because about 12, 13 years ago, there was a wanting to move away from mental health being associated with children. And I think that picture's changed now, and actually there's not that kind of children aren't that stigma against mental health anymore. So in the new year, we are hoping to move to having one single access point within Northumberland for the CNTW offer. And within there will be three teams that work together, but will say what it is on the tin. So there'll be specialist CAMHS that works with children with mental health and who may have a learning disability as well, that need that specialist mental health support. There'll be a clinical autism and ADHD diagnostic service. And I think that title clinical is there a clinical impact on the function? And that's what the NHS is there for. The NHS is not just there just to find out. And that's something that's been supported by NHS England, that kind of way of working in the future. And then there's the ADHD initiating and monitoring service of medication. I think sometimes with children being under the umbrella of Northumberland SIPS, this is caused a barrier to them accessing the right support at the right time to meet their needs. If a child's in the ADHD clinic, they might get seen, if they're under 11, 3 times a year for that medication to be reviewed, 6 times, twice a year, if they're over that age until they're 18. But actually, they need to be able to access counselling in the voluntary sector. They need to be accessing the 0-19 service if they need it, with colleagues in primary mental health. But also, if they need the specialist mental health service, they will have access to that as well. So it's kind of how we move towards that. So that would, and I think that also aligns with all of those referrals that we get. No one knows what we actually do. If you Googled in Northumberland, refer to the NHS for an assessment for autism or ADHD. No one tells you what to do. It's just a CAMS referral criteria. And actually, so it's a lot of work with our colleagues in early help about supporting this referral process. So that's a really exciting time, and that we'll probably be embarking on in the next 6 months to ensure that children and young people's needs are met at the most appropriate time. I think we just wanted to end on about 18 months ago, we had an away day for the whole service, and we came up after lots of debate about having a mission statement. And so the decided mission statement was providing a highly specialised service to support and enhance young, healthy minds in the heart of Northumberland, and we will work hard to help you. So that's what we have committed to in Northumberland as a service. And I just want to say that the actual logo, one of our children that access our service designed this. So obviously we have our therapy, and so we have this, we try and get this out everywhere that we possibly can. But it is about, we all need to work together. Everyone's different. We'll have positive times, we'll have really times where we're really sad, but actually we all need to work together to help all of the kids, and that's what we do it for every day. So thank you for listening.
Thank you very much. We will work hard to help you. That's highly motivating and encouraging. I think the talk was full of information about what you have achieved and how you adapt yourself to challenges. And especially, I commend that face-to-face meeting with children. So that is really a good thing. So let me ask for any questions, suggestions, remarks from the board. Anyone? Okay, so Mark, you want to go first. Are you doing collegiate appraisal here? Or please go ahead. Yeah, and then Jill.
I'm not just saying this because the director sitting next to us by the director. As the staff say, Chair, I am the staff say Chair for CNTW, but with my council here done, I would just like to say it's an excellent service, excellent staff, hard work and dedication in really difficult circumstances, and sometimes negative press. So I think just to take back to the staff and yourselves that from this board, I think you're doing an excellent job, and just keep it up. Thank you very much.
Thank you. Please.
Thank you, and I just want to give Sam the heads up that I'm really interested in your reflections on the presentation after myself. But first of all, thank you for such an honest presentation, and it's been really illuminating. We deliberately asked, obviously, Chloe and yourselves to come and just give an orientation to what actually is happening within your world of work and how you do connect into the other component parts. It sounds really positive and pragmatic, that change in name and call it out what exactly it is, because that overarching title is really confusing, isn't it? So that greater clarity, I'm sure, will help everyone in the system navigate. And it's a national phenomena, isn't it, post-COVID, this influx of demand that you've described. So it's great to hear how hard we are working locally to make that difference. But you can't do it alone, which is why we wanted the conversation to come here, just to see how we all play our part, and going forward how we do that more strategically as well as operationally on that day-to-day footprint as well. So thank you.
Thank you very much. Yes, please, Graham. Yeah.
Thanks. Thank you. Really nice. I've loved the first slide with just everything on it. That was great. And it would be fantastic if we could get you to come to primary care. So just putting my GP hat on, we can open the door for you to come to the GP Collaborative or the LMC or somewhere to just highlight how that looks. There was a couple of thoughts, though. I can see that huge increase in referrals, and yet proportionately, I think there's a 25% drop in the number that get accepted. So that tells me something about they're coming to you to the wrong place first, if there's a greater proportion aren't. I did wonder, we talk about no wrong door. I know at one stage, and I don't know if you still have, there's kind of families can self-refer. So that would strike me that maybe you get more self-referrals, perhaps, than you were doing, and maybe they're already under a service elsewhere, but they don't quite understand that they would be moved to you if that was felt appropriate. And do we have a single point of access for all providers, so that there is none of that, I'm in, now I'm going to step outside the door and knock on another door, because I'm not quite getting what I feel I need. I know as a GP, I have families come to me and say, so the school are doing this, we've got a primary mental health worker, but actually I think we've got ADHD here, and school have said, come and see you. And that, in my book, is wrong. I may have a role to understand and provide information, but it shouldn't then fall on me if the person is already in the system to say, actually, I think I will do that referral for you. So we do still get some of that happening. And then there was a couple of things about, it's interesting, isn't it? As a service, we tend to put DNAs up first, and then you came down to the patient experience stuff at the bottom of the slide. And in the language, there was a bit about managing patients' expectations or families' expectations. And I would substitute understanding in there a little bit. Because actually, I think as soon as we're managing, it would suggest that they're wrong and we have to manage it to get them their expectation correct. And I would say if we understand and just use that language, it might open up different doors to finding the solutions for people. And it's just very subtle changes of language. But it makes... I believe that that's what your service does. You do listen and you do try, but actually it's understanding. Thank you.
Just to come back on about the self-referrals and actually in line with kind of potential the changes that may come with restructuring what we're called and things like that, and in the transformation around the neurodevelopmental assessment pathway, we will be going to no self-referral, and actually it will be like a professional that's been working with the person. I personally don't think GPs are the best person to refer. I think you are so busy and have got, there's so many other things that need a 15 minutes at the most, maybe sitting with a young person to make a clinical decision whether they need to be on an ADHD pathway. That should be sitting within school, and but we need to ensure we get the information from home and school at the same time to enable us to make that decision. One thing we've discussed this quite a bit.
Can I just quickly say that is for the neurodevelopmental assessments only, not for mental health. We will be accepting self-referrals for mental health still.
I was coming on to that. So Michelle and I both, the numbers are so small in terms of self-referrals for the mental health pathway. That's something we would never want to. Some CAM services have gone to no self-referral across the board, but actually if a child or a parent are in so much distress that they need that, if that was our child, we would want to be able to pick up the phone and do that. So that's kind of the caveat that we put against that, was if we went to no a new way of working for the neurodevelopmental pathway for mental health, it would be something slightly separate. I think in terms of your other point around kind of managing parents, carers' expectations, I'm hoping that the implementation of the parent carer peer support worker will have a positive impact on that. I'm seeing that already. Having one person within the assessment pathway, because sometimes it's about school-related issues that aren't often, or you know, we have little control. We can give recommendations about what we feel might be beneficial. So I'm hoping that a role like that will be helpful. And it is really hard, because if a young person is extremely distressed, that is severe to you as a family, isn't it? But yeah, you're right. I think every member of the team would listen and be caring and compassionate to all of those things. But then it's about having the most robust plan moving forward, and who's the right person to contact when to meet a young person.
I think it's also probably crucial to end on what we need to listen to is the child's voice, and often we do hear parents' voice, and what a parent feels the child needs sometimes differs to what the child's asking for. So I think it's really crucial that we do listen to the child's voice also in it.
Yes, please.
Thank you very much for that report. It's so interesting, and it's really great to have it over here in the back, to have it chunked into the different areas, because you've got the children's support element, but then there's also, like you talked about, that diagnostic. And I think it has to be acknowledged that that there is a route way for, you know, poverty is a big issue here and inequalities is a big issue. And the reality of it is, if your child has a diagnosis, not only are you able to access certain levels of support, you're also able to access certain benefits. And, you know, certainly from our work, from CAB work within schools, we are, you know, two of the major issues that we're seeing are disability applications for children's disability benefits, as well as legacy benefits moving from, you know, obviously with everything moving over to universal credit. So it's about acknowledging that. And I suppose from a question perspective is, you mentioned so much more complicated, complex cases. We're all seeing that, I think, across everybody in the room. I'm interested in how your work, because you mentioned there was like no increase in workforce, and you're suffering the same workforce problems that everybody else is kind of suffering from. How are you working with independent, both voluntary sector and private sector providers who have that qualified staff around diagnosis and stuff in terms of increasing that capacity?
I think one, so as part of the graduated response, we the work that all of the NHS-funded services, we also linked in with Cygnus Counselling, and we've got a really good relationship with Amanda Sayers within Cygnus. So we kind of know what their offer is, so it's trying to reach out. We know some schools have funded themselves, psychotherapists in schools. We've got links into all of these different places, and that's that whole thing about getting the right person to meet the needs at the right time. So actually having all of that inside knowledge of where everyone does help us navigate where things need to go.
So how do you make, is there a central, like kind of almost the same as coming into your service? You talked about having a single point of referral, and, you know, obviously we have Northumberland Frontline, where, you know, there could be a way of you utilising that, not just to make the referral system itself, but it's more about those organisations capturing that referral, because when a lot of it will come down to funding and things like that, and then demonstrating how you're able to link up with yourselves and other services will enable there to be, you know, while budgets are pushed everywhere, it's about demonstrating impact and an ability to do that.
Absolutely. And I think that's what we're in the midst and the throes of doing, is kind of, because we have such a number of new voluntary sectors that have popped up, and we've lost a lot as we've gone. So it is navigating. Frontline have just been on Friday to SIPS, so we're just starting to kind of join forces with them and see how we can start working together, and again sharing capacity. So we're not there yet, but that is absolutely on our radar, and we're just kind of starting to get the feelers out there.
Just to let you know about that, if there's search terms that would make more sense for yourselves, then, you know, that is a changeable resource. It's not fixed in stone.
Yes.
And it's just important to know that when people are searching for things, it's obviously been developed and it's an iterative project. So it would be really useful to hear back from you. I know Nicola from Thriving Together sort of leads that steering group. We can change it to make it fit what you guys need as well.
Great, thank you.
Thank you. I think there was one question here, yeah.
Yes, I just wanted to mention, obviously, I work really closely with Michelle and Katie. Obviously, I'm Sam for the 0 to 19 service. And I think what we have done is, over the last 3 years, really, is really support children as a partnership approach, ourselves, primary mental health and SIPS, and work together, and you're right, you know, targeting those families at the right level. And I think as well what comes with that is training. You know, I have to say CNTW have been great with staff training. We have the weekly interface meetings, which are really, really positive to get that child, that family in the right place at the right time. So I think from a 0 to 19 perspective, there's been some really positive work. And, you know, I think, you know, there's been a lot of waiting lists, etc., but they've come down, and I think we're heading in the right direction.
Thank you. Okay. Any other suggestions, remarks? Okay, thank you very much. That closes item. Thank you very much for coming. So we then now move to item number 7. Health and Wellbeing Forward Plan. So if you do have any questions, any suggestions, you can tell us now, or you can email us as well.
I just want to amend, if that's okay, that a health protection insurance report will come in January instead of November, and we've had a specific request from Alistair Blair, Northumbria Healthcare Trust, to put a report on in relation to ageing population and hospital pressures.
Thank you. And I do not have any urgent business. So, but I think, Jill, you would like to share some good news and bad news.
It was just a reminder to the board.
October 24th.
Obviously, we had our closed session last month. We do have our Tackling Inequalities Through Housing conference on the 24th of October. We are full at 120 capacity, which is just phenomenal, of a really good blend of the right people. We do have a waiting list, so I hope all of you got on there. And if you feel that you should be there and you're not, then please do let us know. But we've got delegate packs going out, so it's all steam ahead. So thank you to all those, looking at Claire over there, who's been part of the coordination team. So I'm really looking forward to that being a positive and inclusive event.
Okay. Thank you very much. I think, so the final item is to note the date of next meeting, 14th of November 2024, 10 a.m. in this place. Thank you very much for all your contributions and your presence. Thank you very much. Wish you all a good weekend and a good week. Thank you, Andrew.